The pain is radiating type, pin pricking, is it? Okay.
Yeah. Good afternoon, everyone. Welcome to our yet another monthly session. This is the South Asian Bioethics community. We are a group of healthcare researchers and activists who are interested in the question of ethics in the South Asian context. And our aim at this community is to have monthly reading groups, webinars, conversations like today. And we are very glad that today we are going to talk about a very important topic, which is disrespect. And we have with us Dr. Supriya Chattopadhyay, who is an associate professor of sociology. She is also the co-anthropology. Her research focuses on public health, fertility intentions, and gender-based violence. Her first book, The Gravity of Hope, will be published shortly. And I've had the opportunity to be with Supriya in one of the panels a few months before. So I've looked at her work closely. I'm really glad that she agreed to do this with us. And with Supriya, we have in conversation today Dr. Supriya Subramani, who is one of the founding members of South Asian Bioethics community. She's the visiting fellow at the Prof Foundation, Switzerland, and her research interests lie at the intersection of emotions, healthcare ethics, and behavior. She focuses on microinequities, moral habitus, the social construction of incompetency, and the experiential aspect. Currently, she's working on her book, The Passive Patient, Culture of Disrespect in Indian Medical Law and Clinical Practice. So in today's conversation, Supriya and Supriya will critically reflect on their particular research and share with us the key learnings, add key insights, and engage with methodological challenges and opportunities in researching topics like obstetric violence, inequities in hospital settings, vulnerability of the researcher and the researched, etc. So over to you, Supriya and Supriya. Thank you so much for doing this for us.
Thank you so much, Priya, for the quick introduction. And this is really great. I'm super excited to have this conversation with Supriya and of course with all of you. So before moving forward for the main session, I thought I'll just quickly give you an overview of what we are going to do this for the next 50 to 60 minutes. So 10 minutes each, like Supriya will start off with giving a perspective commentary on our common themes, our common ways of insights, which we bring in with our works. And then followed by myself, like I'll give a 10 minutes commentary. It's a perspective again. And then 15 to 20 minutes of discussion between Supriya and me, like myself, we will have this conversation. I'm sure Supriya has a lot of comments, thoughts, reflections, and I do have quite some. And then we will open the floor, followed by that for 20 minutes Q&A session. So this is how it works for today. So the floor is open, Supriya, for you, and I'm looking forward to it.
Thank you so much, Supriya and the South Asian Bioethics Forum for inviting me. I greatly enjoyed reading both of Supriya's articles. And in fact, I've been following her work for quite a while now. So it's been a real pleasure to engage with her work. So what I'll do is I have written down my comments, and I'm happy to share this Word document if someone needs it, because I didn't prepare a slide after the presentation is over. So Dr. Supriya Subramani's essays addresses two very important issues in health research: the questions of micro-inequities and dignity, as well as the question of reflexivity. These papers are meticulously researched, engaging, thought-provoking, and provide a springboard to ask many interesting questions in the ways in which we conceptualize and practice research, especially in health settings in the South Asian context. The first paper focuses on micro-inequities. What are they and why are they important to address, especially in the analysis of provider-patient power asymmetry? Subramani argues, and I quote, micro-inequities are not blatant forms of discrimination. They are minute expressions in events that may or may not be recognized by victims and perpetrators, end of quote. She describes micro-inequities as behavior that is covert, unintentional, frequently unrecognized, and perhaps unacknowledged too. I mean, this is the kind of question that I have, that it's not only unrecognized, it's also unacknowledged, both by the perpetrators as well as by people on whom this is inflicted. Microinequities are often experienced as forms of marginalization that take place along axes of social stratification, such as class, caste, gender, ethnicity, religion, age, etc. In her words, the aims of the essay were, quote, to capture micro-inequities through qualitative analysis, highlighting the need to emphasize the moral significance of micro-inequities in the doctor-nurse-family-patient relationship and healthcare system. She clarifies that the purpose of the research was not to determine whether social inequalities were present or not, but to explicate how micro-inequities influence relationships within hospital settings by mirroring and extending inequalities in society, and how micro-inequities diminish the dignity of patients, family members, and result in poorer communication and an eventual normalization of these experiences. The paper uses a constructivist interpretive paradigm, an inductive approach that foregrounds perspectives of affected individuals and lived experiences. The positionality statement clarifies authors' own position and experiences of both microinequities and blatant forms of discriminations that shaped her interest and analysis of the data. Subramani helpfully clarifies that microinequities are an interplay between two experiences. And I think this is key for us to focus on because it is both interpersonal discrimination and micromessaging. There are several insights that emerge from her analysis. Some of this will be quite, it'll resonate with many of us who have worked in healthcare settings that are indeed sort of, work with both patients and providers. The first is that authoritarian behavior is perceived as care by healthcare providers. This normalizes reprimands, scoldings, and sometimes yelling. This is something that I have encountered in my research with pregnant and laboring women. And it has also been documented in other low and middle income countries, particularly those that are going through, rapid demographic transitions and shift from home to hospitals as a site of birth. The second is that patients in government hospitals feel disempowered. They are not always able to ask questions. They feel that care is charity, which is bestowed upon them because they are poor. They're often belittled and disciplined in ways that put them in their place, whether providers intend for this to happen or not. Thirdly, providers admit to acting like God because patients are poor, illiterate, not able to understand, and therefore providers feel that they need to hold the reins of patient care in their tight-fisted manner, leaving little room for questions or a meaningful dialogue. Fourthly, interestingly, and this is something again you see in the scholarship on disrespect and abuse, with pregnant and laboring women, is that in private hospitals, micro-inequities also exist, but they do play out differently. People who were perceived to belong to rural areas were subjected to it, but levels and frequency were clearly much lower than in publicly funded institutions. Also, gender and place within the household has a role to play in how micro-inequities were experienced with women, and especially younger women receiving the brunt of it. And people in private hospitals, and this is something we have seen with the huge privatization of healthcare in India and elsewhere, that they have more rights in asking questions, but it is not a right as we understand in human rights terms, but the entitlement to ask questions because patients are seen as paying customers for a service that are provided. In conclusion, this paper highlights the importance of micro-inequities in health settings because despite being transient, they are normalized through knowledge, professional roles, and are part of larger inequities at institutions. The second paper on reflexivity, which also I greatly enjoyed reading, argues that while there are different kinds of reflectivities, but it is important to, quote, identify how reflexivity is practiced and adopted, who practices it, what the research is on, and what the researcher's agenda is. Each researcher embarks on their reflexive journey by giving significance to what they think is crucial to their research. So this is no secret that reflexivity is key to assessing rigor in qualitative research. The author describes the reflexive moments that she experienced in her research due to her experiences of being a patient or a caretaker. She describes authoritarian and rude behavior that she experienced from doctors when she asked questions about her condition. I think this is something which all of us can relate to, being gaslit by doctors and sort of being told to not ask too many questions lest their authority be challenged. As a caregiver, when her father had heart surgery, the questions of Subramani and her mom were met with curt replies. These experiences, she says, shaped her research questions, which was trying to unravel microinequities, power dominance, informed consent in doctor-patient interaction. I would comment that this is in fact typical of most feminist epistemology in terms of how we arrive at a research problem and the continuous refining of research questions. And in this particular context, Subramani described that Sharma's work informed her position around informed consent and argues that consent is a process which has to be understood within the subjective meanings of constructed reality and not as a process within an objective world, end of quote. So clearly there are multiple realities, and perhaps the search for pure objectivity is an exercise doomed to fail, I would argue, and may not even be helpful in answering very naughty questions. So these two interesting papers had me thinking about how we theorize disrespect in qualitative research. Symbolic violence and the use of symbolic and cultural capital using Bourdieu's framework would help us understand how microinequities are routinized, and indeed why some medical professionals or anyone in a position of authority is able to get away with being more inequitable and in more ways than others who are not in that position. While Subramani's research already implicitly does this, I do have a few questions, and this we can take up in the Q&A, which is, if we were to extend this work using an explicit Southern decolonial perspective, what might we learn? The practice of reflexibility largely seems to have emerged from a primarily Euro-American white perspective, although within anthropology, there are exceptions with scholars for what reflexivity might mean for someone who inhabits multiple identities simultaneously. For Southern scholars like us, who may indeed embody multiple identities at the same time, some disempowering, such as being people of color working in predominantly Euro-American countries, or being women working in largely masculine settings, others may be empowering, such as being of a higher socioeconomic or caste group than interlocutors. So how might we conceptualize reflexivity given these different kinds of situations? Moral knowledge and moral practice, a concept elucidated in both articles, demand that we practice ethics in a way that centers autonomy for the individual. However, in many low middle income countries and resource poor contexts, healthcare decision-making is in fact relational and a shared activity. So how might we translate this in a way that is also culturally appropriate? While I do not advocate for surrogate decision-making in all contexts, it is the case that often given structural constraints and familial dynamics in South Asia, the patient is not the sole decision maker. Another issue to consider is that in under-resourced health settings, there are no doubt highly inequitable spaces. It is also the case that health providers combat a lot of stressors and constraints. Is there a way in which we can incorporate that perspective while also being mindful of the disrespectful and abusive behavior that are inflicted on poor patients? In particular, violence against healthcare providers and politicization of tragedies such as accidental or inadvertent patient deaths also deserve scholarly attention. Does the potential for systemic change expand? And this is something we can all think collectively. If one were to adopt a less antagonistic language and understands where there are no pure villains or heroes, but ordinary people trying to work under extraordinarily stressful circumstances. True reflexivity in the ways that these two papers demonstrate require a reckoning with our own vulnerabilities and an openness that requires introspection and asking difficult questions. I'm mindful that these are challenging times we live in the era of identity politics, cancel culture, extreme polarization, hyperbolic statements, and mandatory D&I statements being demanded even for conference presentations. I worry that reflexivity may be reduced to another tokenistic exercise unless we take stock of the constraints that we work within. So that's the bit from me. And Supriya, you can take over.
Great. Thank you, Shripana. I think you touched upon a very important conversations, which definitely I would hope during the discussion we continue this, especially on how do we reconcile and be vulnerable at the same time, engaging thoroughly and be reflective and not leaving it to the token discussion, which it usually ends up with, especially when within bioethics circles is happening with last few literature discussions. So I don't have PPT too. I have written the commentary and I'm happy to share. So there is the growing body of literature that recognizes the importance of engaging critically and to address obstetric violence. As Sriparna has highlighted, that focusing mainly on the technological dimensions of the labor process have led healthcare professionals to neglect the emotional and social aspects in their relationship with women and their needs. So Sriparna, along with her colleagues, Arima and Suraj, brings an brilliant and eloquent way of sharing women's experiences, pain, and also the voices, particularly who belong to lower socioeconomic status in rural Assam. The key insight of this paper, which adds to the larger ongoing debates within healthcare research and ethics debates, which I'm trying to connect from from your work, is the struggle to achieve humane and ethical care within the structural challenges we have, especially the resource crunch, resource scarce settings. And the overemphasis of biomedical institutional forms of care, in this case, as you mentioned about the number of institutional delivery or the idea of the safe birth, so the numbers and statistics over the humane approach. So as Sriparna illustrates through the women's experiences, how considerable symbolic and tangible forms of violence during institutional deliveries exist, which is also normalized and also which perpetuates within itself. So, which I also illustrate, as Sriparna mentioned, within the larger general surgery wards, both in public and private hospitals, to varying degrees. So public hospitals have a different kind of intensity, whereas versus the private hospitals has different intensity. So one of the things that keeps popping up in my work as I was reading Sriparna's work, not just this work, even the earlier works, which you have worked on, is how we can move beyond the structure and agency dichotomy, which we usually end up with, which I am also tempted to use in most of my earlier works. And even, for example, the idea of passive versus active patient, or the perpetuators versus victim, which in microinequities paper, I tend to use this, but maybe we can discuss this. How do we have the right language to discuss these? But in order to understand the phenomenon of obstetric violence and the larger phenomenon of disrespect or disrespectful experiences, we need much more than simple binary structure in order to address the role of individuals within the systems of violence. In this case, when we talk about healthcare professionals within the larger Indian healthcare system. So while I agree that healthcare professionals become perpetuators of violence as part of systems of violence, but there is nevertheless still a sense in which individual responsibility can never be totally erased or diluted. So as Sriparna in her works clearly illustrates, which I totally resonate with, that these structures, along with the individuals who take part in them, need to be addressed, named, and their experiences unpacked, whether it's patients, especially the vulnerable, women experiences, but at the same time, when the healthcare professionals, whoever is involved as part of the larger healthcare institutions. If we want to really understand and tackle the phenomenon of obstetric violence or any phenomenon of disrespect in that sense. So thus, the way I would see is that the healthcare professionals, whether medical practitioners, surgeons, obstetricians, or any nurses, are themselves treated violently by violent systems and structures on one hand, which in turn make them act in violent ways towards patients. I mean, I'm just tempted to say that, but at the same time, to illustrate, for example, we can talk about lack of institutional support or hidden underlying gendered, casteist, class-based and patriarchal and heteronormative. All the big issues which we do grapple with, and the hidden curriculum which many doctors learn and many healthcare professionals learn. So of course, as many feminist scholars question, like as Sriparna also mentions, I would question too, how to break the circle of violence. So on other hand, I do see that one needs to be accounted and held morally responsible and hold it, especially when there is an unfair treatment, when you can clearly see there is an unfair treatment. So of course, we can discuss this later during the discussion. So the larger theme, which I think to explore further, like looking at Shripana's work, is how do we women or doctors or healthcare professionals identify violence amid the structures that constantly reproduce normalized violence or the normalization of disrespect, which I would see it as a culture of disrespect, which is so normalized. So especially when we ask any doctors or nurses who actually believe that they are acting in the best interests of patient. I mean, during my whole fieldwork time, when I interviewed all the healthcare professionals, they really believe they're doing good, right? So then how do we understand this, what's happening? So that's something is quite hard, isn't it? I mean, the way the instances of microinequities or the larger disrespectful experiences Shripana brings out. So, I mean, in order to just illustrate that, for example, if you say that you were rude as a doctor, that you did not do an eye contact or your body language was not very empathetic towards me, but the doctor might say, wait, I did not do that, right? I mean, that can also happen. I did not mean it, or I didn't intend to do it. These questions comes in. So this, of course, cannot be taken lightly, and the argument needs to be rethought and made more complex, since otherwise this could turn into completely trivialized and relativized approach to the question of what constitutes violence or disrespect, or who is violent or who is disrespecting whom in that sense. So we do not want to agree to this purely subjective perception. I mean, I'm pretty, on one hand, it's quite questionable, okay, it's a subjective experience, but then I would hesitate because there is a power there. And that's where the focus of power relations matter crucially, and all intersections, right? It's an intersectional categories which plays in. So given that women, and as Shripana clearly illustrates, women and poor women, particularly the patients, are situated within these power asymmetry, both structural and within the doctor-patient interactions, it becomes necessary to learn to listen to and think about these voices differently, and in relation to their specific position within the relations of power. So the key learning for me when I'm looking at both the works, Shripana's, the Safe and Violent, and also the focus on the gendering emotions, is about the focusing on voices, that is experiences, capturing the lived experiences plays significant role for us to understand the larger context. So to conclude the commentary, when reading these experiences of vulnerable patients, whether in Shripana's work or my own work, being, or many other scholars' work, amazing works many scholars have been doing in South Asian region, we can clearly see what are the normative expectations in everyday interactions. So when I mean it's a normative expectations, usually most of the bioethics discussions, we end up thinking it's too abstract, too West. The idea is very objective. There is certain moral truth or moral normativity. But what I'm looking or trying to understand is by the experiences, that is the way we capture the lived experiences, that is, we can see the intuitive notions of justice violated. When we look at the closely the narratives of each woman, the way they share their experiences. So when we closely listen to their experiences, the normative core of such notions of justice is always constituted by the expectations of respect for one's own identity, one's own dignity, and also integrity in the everyday interactions. So I would see that it's a moral recognition, that is each other as a moral person, not just because you are an academic or you are a doctor or you're just having a certain social status, I respect you, but you, because you're a person, you're a moral person. So that's a recognition, is very fundamental. When we are in this intersubjective space, so when I mean intersubjective, just when we are interacting within this, the space where the doctor-patient interactions, or the women is interacting within the other nurses or any other healthcare professionals. So it's more of, we expect certain reciprocal recognition as moral persons. That's what respect is, in the way I would put it as. And it's an experiential aspect. How do we play it out is a bigger challenge, definitely. And so going back to the question of obstetric violence, the large I was thinking is respect. Is it an issue of, or it can be an issue of patient safety? I mean, looking at obstetric violence, how do we connect to the larger discussion of patient safety is something which I think to explore more. And I think the acts of disrespect that we come to accept as a way of life in medicine, especially biomedical gaze, which we do have in, showed how these can lead to a final pathway of harm to our own vulnerable patients, as Shripan also highlighted, the vulnerability plays out in different ways. So at one end of the spectrum are the examples of very outright, overt disrespectful behavior, and the volatile doctor everyone knows to steer clear of in that, the very tiny ways. But then there are sadly common abuses, which clearly Sripana brings out, which is an overt, and then medical negligence is also very clearly there through the work which is mentioned. So as Sripana in her works brilliantly illustrated how obstetric violence is experienced and how disrespect is part and parcel of that experience, whether it's overt or it's as part of microinequities in itself, which I would say is morally unjust when persons are denied the recognition they feel they deserve. And the question is now, who feels how they experience it and who dismisses that experiences within the larger structure is a big question. It's not just the philosophical, but also very much experiential in that sense. So talking about methodology, I have lots. I have a few more sections, but I think I'm running out of my time here. So maybe we'll pick on this during the discussion, especially talking about gendering emotions and how it connects to the larger leaning towards, is it the scholars, our feminist scholars are always reflective? Is it only the women who do this? I'm just curious how to explore these questions, but yeah, we'll continue the conversation. Sripana, please. Do you want me to ask a couple of questions and we can start off the discussion, or how do you would want to?
Well, I can see that you have raised, two big questions. One is, I suppose, unpacking what respect really means, right? In the context of healthcare settings, whether that's in obstetrics or something, general surgery or any other branch of medicine. And the second question you asked is, are all feminist scholars reflexive? And is that are the women only doing it? So I just want to maybe take the second question first and say that, feminist scholarship is not just limited to women. It's also a lot of queer theory and queer scholarship is part of whether it's feminist anthropology or gender studies has come into it. So I think that the method also emanates from our own personal experiences of, whether it's marginalization or the lived experience is definitely really important. So I think that reflexivity is not just natural, but it's actually a requirement for any kind of feminist scholarship, right? So that sort of, and we can have more in the Q&A around the methodology as well. But the first question that you raised around respect and disrespect and what does it mean? I think part of the problem which many and I'm not the first to say this, I think this has been highlighted by many scholars, is that the narrative and the discourse around respect is very strongly linked to health systems and the kind of health systems that exist, right? So believing that health is a fundamental right in the concept of, human rights language, which is not a Western concept, but I think the People's Health Movement has done a lot to bring that notion back, saying that health is a right. And so when you go to a government hospital, it's not charity that they are doing, it's your right as a citizen. You are entitled to good services, right? And quality services and respectful services. But unfortunately, with the extreme privatization, the technocratization of healthcare set across the board, but particularly I think in maternal child reproductive health, in many South Asian contexts. And I would squarely lay the blame on a very large multilateral organization and philanthrocapitalism for changing this discourse and this language, right? So where healthcare has now become privatized and you pay for a service rather than you're legally entitled to certain services by virtue of being a citizen. So until and unless we are able to shift this discourse through large structural changes, I think, respect will continue to be transacted in the language of customer-provider relationship, right? rather than in the language of rights and entitlements, which people hope to have from the welfare state. So that would be my response to your first question. You are muted, Supriya.
Sorry. So, I mean, the larger way of looking at, the bioethics discussions, which even it started with is like respect for, I mean, even though respect for person, of course, going with the US idea of Belmont report, they talk about respect for person, and then we moved away. And then there's a lot of discussion on autonomy, which then many of the South Asian scholars have questioned and critiqued. Then the question is, when we also are critiquing, we are only focusing on a relational autonomy point of view. It's like more still within the idea of capacity and capability. That's something which I'm like noticing and more. But then the moment when we talk about experiential, that is when I talk about disrespect or the respect, it doesn't follow the idea of agency debate. It's more about how we are perceived, how our body language, how we are embodied to each other in our particular context. Now, that is very much part of feminist, philosophy and larger feminist, epistemological concerns in that sense. How do we relate to each other? And there's huge work done on ethics of care. Now, the question for me is like somehow by emphasizing ethics of care, when we put it within the larger patriarchal and hierarchical system which we are in, do we end up using somehow the paternalistic behavior in certain ways? Because we focus on care and safety, that is like, talk about, let's get the surgery, the safety, which you also talk about, right? In the safe of, births, numbers and quality, but then do we miss out on human care if we move away? I'm just thinking out, I'm looking at different aspects. And what are your thoughts on that?
So I think that, it's definitely important to focus on both, right? And your perspective is a lot more micro and experiential in the papers, and rightly so because of your methodology. And I sort of like to both zoom in and zoom out, because for me, these are not, the way I see it, these are not completely disparate, conceptions, because the way safety has been conceptualized in reproductive health and maternal health has been in a very narrow technocratic way, right? So safe motherhood initiatives have been reduced to numbers, and while for countries, in that epidemiological transition where you had very high maternal mortality ratios to begin with, and a lot of disparities within the country as well, this was the first step. You had to do this, you had to address these issues. But moving beyond these, right? So now we are in a regime, at least in India, where the overwhelming majority of births are in institution. And there has been, and I'm sure Priya will comment a lot more about this because her work is on midwifery and doula and all of these kinds of practices. But also these practices often tend to be elitist and very out of reach for the, sort of ordinary individual. And my question is that, humane care and safe care doesn't have to be a trade-off. Right? Safe care can also be humane care, but it also means we need to invest a lot more in the curriculum, which you mentioned, right? And sensitivity cannot be an afterthought. So there's a lot of emphasis on clinical competence, but not so much on, communication or on what they see as the softer aspects of being a doctor. Because clinical competence is held at a very high level, because ultimately it's about numbers. It's, you make sure that the person who is under your care doesn't die. So I think that, there needs to be also the social determinants of health framework, and making providers sensitive. And I think what is really nice about your article, Supriya, is that you make this distinction between female healthcare providers like nurses in private versus government hospitals. And often we think, and a lot of Western literature actually talks about how female healthcare providers often tend to be extremely disempowered themselves, right? They're given all the responsibility but none of the autonomy. And I remember in my field work, in rural Karnataka, which happened under the aegis of PHFI, there were female healthcare providers, nurses who just broke down and cried. Like, I just had to ask them, how are you doing today? That was the only question. And the burnout was so high, right? So they were, so like I said, they are, ordinary individuals who are working under extraordinary circumstances. So in terms of, the kind of micro inequities, microaggressions that we experience on an everyday basis, right? I think that's also the outcome of incremental stress for healthcare providers. And I think that's also something, along with the curriculum, along with everything else, the resourcing has to be adequate so that healthcare providers feel prepared to handle this when they are in stressful situations.
Yeah, I totally completely agree and resonate with these ideas. I mean, it's always, I mean, in the beginning, when I started my fieldwork, I was holding, I want to hold doctors, someone accountable when there is an unfair treatment, when they're treating two different patients differently, or the nurses differently, because of the social markers we just, carry and embody when we move around to different hospital spaces. But then within each of these institutions, it has its own different set of cultural norms and institutional norms, and also the training, as it is a larger approach, how the medical ethics training, forget about medical ethics training, the medical training in itself is how biomedical, strong biomedical training we have in that. And then, as you really rightly mentioned, is it becomes a soft, but that's fundamentally the whole way you keep the medicine and interactions with patients alive and keeping it humane in that sense, or ethical also. So humane and ethical, I'm trying to use it as interplay in that sense. So going back to the methods conversations, I was thinking about, what do you think is the role of ethics committee within the qualitative research or anthropological or social research? Because this is something many of the ECRs within India, we're struggling. So I'm like, yeah, what are your thoughts on this?
Well, I am part of my university ethics committee, and Dr. Jisani knows this well, because we had in fact invited him to our university to give us some guidance, because we are trying to develop a robust institutional review board. And the one thing that I'll tell you is that there is very little understanding of participatory, reflective, qualitative research and what that entails. And there is an automatic assumption, thanks to a lot of misunderstood, I would say, and very sort of selective drawing from Belmont report, that research has the potential to cause harm. And if you're doing participatory research on sensitive topics, on questions of violence, the automatic, I can't tell you the trouble that I went through to have one of the master students who I was supervising to get her proposal passed, because her project was on digital misogyny. And the assumption was that the questions are going to be automatically triggering. So I think that we also need to move away from this assumption that any question that we ask is somehow harmful. Yes, research has the potential to cause harm, and God knows there has been enough, in biomedical research and also some social science research, which we have seen are real malpractices. But I think the pendulum has shifted far in the other direction, where everything and anything is triggering. At least I can speak, for the Indian context, that especially urban Indian context, that this is true. Whether that is in academia, in teaching, or in research. So I think that we also need to kind of, dial down how the potential for harm, right, in research, and understand that yes, we have responsibility, and we need to train researchers so that they become reflective, because you don't automatically become reflective, right? It's a training, and that can only happen within very close mentoring programs, and where the person who's supervising you can help you think of these things. At least for me, the article that I wrote, Gendering Emotions, that was several years after I had finished my PhD, and I had, so much of life had happened to me by that time, that I had the chance to actually reflect in a way that would not have been possible for a 23-year-old researcher when she embarked on her research project, right? So I think that giving that time, that space for thought and slow research, so that you are able to sort of capture the capaciousness, because it's a human experience. And I think people don't understand that to be truly authentic in doing this kind of research, it's also a very painful process for the researcher. We bear witness, to harm, to violence, to these stories. And what does that do to us as researchers, right? So I think in the social work literature, there's a lot of scholarship on vicarious harm and how listening to these stories can. But in the social science literature, we try to stay away from these very tricky and issues, and we sort of write ourselves out of the text. But I think in feminist research, at least as a subset of social science and humanities research, I would say there has been an emphasis in engaging with these issues more directly, because it makes the research more rigorous, solid, and also explains our own positionality in terms of why we choose to do this.
Yeah, definitely. I mean, I centrally think like the integrity of a researcher, especially, is very central when you go to the field or when you're interacting with anyone. But then now the question is, how do we teach a person integrity? And as you said, to reflect and to be part of that process and learning from each other, especially with mentors, I think it's very significant and important. I know we are running out of time, but do you have any key thoughts or comments which we need to continue, or we can open the floor and then we can continue these conversation?
So one thing that I would like participants to reflect on is thinking about what us, like one of the questions that I raised, what a Southern decolonial perspective might lead in terms of our understanding of doing this kind of research. Because the people that we cite, what we draw from, including in my own research, has largely been this kind of Euro-American perspective. And I'm not saying there's anything wrong with it, but I think that we also need to engage with what does it mean for someone who is in the global south doing research in this manner, with the constraints, and how would things be different, and what kind of reflections might you have that sort of sets it apart from, let's say, a northern researcher doing this.
Great. So one of the thought which came in, and then for example, when I was reading all the literature within bioethics, which is dominated by global north discussions and the ideas. So most of my works definitely are influenced by continental philosophers and also analytical philosophers. And being placed within the interdisciplinary field in itself is super challenging to grasp these. And then finally, I realized, I'm going behind the concepts and then learn from different approaches and frameworks, and then make sure the transparency of each methodology plays out, but then critically question when we apply within the context of India. But at the same time, whenever we talk about respect, is also seen as something as very West and elite, and that I'm super surprised by that. Why? And why respect is something West and elite, but because every day we constantly, in Kannada, I can use many words to say. In Tamil, there is so many words. In Malayalam, we constantly keep saying, hey, give me respect, is something which is so common in our everyday interactions. But then when it becomes a moral concept, why are we thinking it is something West? This is something which I want to put it out to think through, and we can discuss it later. But now we are open for Q&A sessions, and then please just shoot away your questions. And then it would be great if you could switch on the video. It would be nice to see. But if it is something uncomfortable, it's okay too. And please raise your hand so that we know the order who want to have questions, and then please unmute yourself. You're all thinking and processing, I guess. Yeah. Priya, please.
Yeah, so maybe I'll start. I'll just want to put a note here, which I have put twice in chat, that please check your names, because you might raise your hand and all of you might read Supriya Subramani. So please check your names and change them. So yeah, that's just a note. But thank you so much, Supriya and Shripana. It was a great conversation and a lot to think about, because as Shripana mentioned, I work. Uh, my own research has been on surrogacy, but I work on midwifery and doula issues as well in the Indian context, and my work is located in ethics of care that Supriya brought in. So I do have a few points, but I'll just put two of them first, and then maybe I see another hand that has been raised from Swaleha's office. So we'll go to that. So I just wanted to kind of put out 2 points. One, going back to the healthcare workers, and where Shripana and Supriya, both you mentioned about their vulnerability and their being overworked. So it reminded me of the fact that how Indian government, for that matter, has come out with these guidelines around midwives and institutionalizing midwifery as an antidote or as a solution to, say, maternal health issues or the violence that we find in largely to sexual reproductive and maternal health issues. So just maybe say pushing in more institutionalized midwives is seen as at times the solution to this, uh, without reflecting on how they are also placed in their situations. For example, as Shripana had mentioned, I remember the cases of ASHA workers, because ASHA workers, especially in COVID and beyond that, were really overworked and not underpaid, but not paid at all. So, and you know how they are themselves. So ASHA workers, for those of you who are not from India, are the community, health workers, mostly from those villages only. So in my own village, and I'm right now in my village in Himachal Pradesh, northern state in India. So given they are from the local communities, at times their own local dynamics come in, hinder their work. So for example, the ASHA worker in my village, when she decided to walk out of her marriage, the entire community of the village, led by women, wrote to the higher authorities to take her away from the position, and to take whatever she had done, to just write against her. So there's so many issues involved with the local workers, because they are so much entangled in the local politics. And of course, there is that dynamics of power hierarchy between the local worker and, say, a doctor. So one is that, for that matter, that even if you flush more midwives into the system, and one of the projects that I work on is critical midwifery studies, where we are taking these questions. We also have to kind of reflect on the internal power dynamics that they themselves face. And if you go in the global north context, the kind of treatment met to the people who are from marginalized communities by the same midwives. So that kind of power dynamics there as well. And to the question of ethics of care, and I'll just stop there. You rightly pointed out, Supriya, that at times that when we talk about ethics of care and relationality and responsibility, how do we take care of the fact that it is not yet again seeping into the same patriarchal or unequal system? Because that was the critique of ethics of care in the early years, in 80s and all. But I believe, and because I am working in that literature, that there has been a lot of move and shift to move towards feminist ethics of care from feminine ethics of care. To not kind of just look at care in that patriarchal system. That are we again essentializing the care aspect of women, and then saying that, okay, we have to look at that. But I guess, like Shripana said, safety and humane care, responsible care, and looking at people as not just independent autonomous beings making these decisions, but relational beings. But part of those relations, and I think that's where the ASHA workers example can also come in. I'll just stop there and let others come in.
Great, thank you, Priya. I think that's something which is very important. Like ASHA workers, most of them are women, right? So is it because of they are women, they are underpaid, are not valued in the system? I mean, that's something which we can think through again. But yeah, so let's have the question from, I think, the office. So I don't know.
I'm so sorry. Can I just interject, because on the area of on the area of ASHA workers, we have the same issues with the lady health workers in Pakistan. The most, of course, lady health workers, they're all women, and this was this case in Pakistan during COVID. They were largely underpaid. They faced a lot of violence because a lot of their work is related to vaccination programs. And vaccination, especially for polio, has been a contentious issue within Pakistan. So we've had similar experience. I just wanted to share that. I didn't have a question.
Yeah, thank you. Yes, please. The office. I mean, I don't know, how do I address?
Hello, everybody. This is from CBEC in Karachi. My name is Dr. Farhat Muazzam, and I've really enjoyed what has been said so far, primarily because I'm a surgeon. And all I want to do is just share a very quick episode with you folks, which is our struggle on the issue of respect, etc. I'm a female surgeon, and we have another female surgeon sitting here. So it was kind of interesting to listen to this from a kind of a different gaze. Yesterday, I gave a talk in one of our leading institutions over here. And the title of that was, we are surgeons, we operate, you do the bioethics. And this was a surgical grand rounds. And the interesting thing was, and there were a few female surgeons there too, that what you're talking about, the issue of respect, I've always had a problem with the word autonomy in my field. I'm not a researcher primarily, I'm really a physician. And the interesting thing was that one of the female surgeons who teaches bioethics over there asked a question or related, what she narrated was they're teaching their students bioethics. And in one particular episode, which was on informed consent, there were two female students and there was a couple. And so they were showing them, how do you take the informed consent? And after all that, the student, it was one of the female students, when it came to sign the consent, the procedure was on the woman, she handed the consent to the husband. And so she said, so this particular female surgeon said, I didn't know what to do after that, after I had gone over everything. So what you're talking about is really, it's a broader issue that seeps through not just in research, but also in our clinical practice. So, and in this, women are complicit. So it is not an issue of women being all the time oppressed by men. We are very much part of that. So this is just a comment I wanted to make.
Can I also make a comment? Although I'm not a female surgeon,
yes,
surrounded
please.
by women.
We need more perspective.
He is just a surgeon.
Yeah.
And he does bioethics. So you've got surgeons sitting here listening to you folks.
And an honorary woman in this setup over here. So,
That's great.
So when we were doing this exercise, again, of trying to make sure that informed consent is understood by the practitioners, the physicians, the nurses, the medical social officers at our institute. And we went around in all the departments talking about informed consent, and we were introducing a proper informed consent form over here and transitioning from a much more rudimentary one some years ago. And we would explain the concept of respect and the concept of respecting the individual whom you're going to operate upon, and the reason why they need to be informed and they need to consent and they need to have it done voluntarily without coercion, etc., etc. We explained this in great detail to a bunch of nurses and all women, well, primarily women, but a few men also, but mostly in Pakistan, nurses, the profession of nurses is dominated by women. And so they all understood that, of course, consent has to be taken from the woman. If it is a woman who's being operated upon for removal of a gallbladder or done for hernia or a breast surgery, whatever it is. So it should be the woman. They all understood that. So when I asked them, when we asked them, okay, if you were to be operated upon, who would give consent? Which is, of course, my husband. So while they were looking at the procedure and they seemed to understand the concept of respect, etc. When it came to actually playing it out on themselves, they were quite comfortable in delegating the autonomy or the process, at least, to their husbands or to their elder brothers or their brother or their father or whoever it was. I'm not sure how they personify themselves, but this is how it played out in our practice over here.
And of course, Amir and I, because we come from, as you've pointed out, our basic literature is the Americanized. We were just scandalized. But when we talked about it, There may be reasons why they wish to do this, and we need to understand that. And the authority thing also works within the informed consent for male patients who come in. Often they will say, my older brother or my father, aap unse baat kar le, and they will sign. So I think it's a very complicated issue, which is not basically just a feminist gender issue. That's there. But I think it is much, much broader in the societies we live in and practice.
Yeah, thank you. Thank you so much. I think that's, I mean, quickly before moving to Shripana's comment, I mean, I'm curious to see what Shripana has to say. I just wanted to put it like, usually we think by talking about informed consent or about autonomy, we are valuing respect. I would say that's not the case. Respect is something which is not necessarily always, if you respect the decisions, like for example, consent signature did not necessarily means you respect that person, that experiential aspect of respect. Because as Shripana's work and many of the feminist scholarship and many health inequity scholars bring out that micro level interactions by pinching a person or by beating or by even with the body language or with just silence, you can disrespect a person. And of course, the signature can happen is, of course, it's a different. So I think on one hand, it's a decision-making issues, which who makes the decision, how respect is acknowledged in that sense. But on the other hand, it's also the idea of respecting a person with experiential way of during the interactions. I mean, I think it's interesting to bring in different ways of looking at how we conceptualize respect. I mean, I can see this different narrative, but yeah, please, Shripana.
So a quick couple of comments. Thank you to the two surgeons for bringing this up. And I think it's really important to recognize, and when I said a Southern decolonial perspective, this is exactly what I meant, that in the everyday decision making, a woman in a family cannot be the sole person who decides whether or not a procedure takes place on her, because she is actually dependent on relationships of care. Right. So in India, for example, in government hospitals, if you have a surgery, even in private hospital, and you need blood, your relatives have to run around to get that blood. So if your husband or your father or your older brother is not signing off on that, who is going to arrange for that blood? Right. So they have to. So, this idea that autonomy, and you are right to have a problem with the concept of autonomy, the fact that it can be individualized to this extent is where we have a problem. And the second quick comment that I wanted to make is that I don't think feminist research is only about gender. I think it also encompasses all these other, stratifiers, whether that's age, whether that's relationship, whether that's caste, ethnicity, all of that. So, and women are complicit in patriarchy. We know that.
Yeah, patriarchy doesn't have gender, right? So, sorry, Mala.
Good afternoon. I think I just wanted to pick on what my colleagues at CBEC had said to point out from the discussions that have happened up to now, and looking at what Shripurna has said, maybe, we need to revisit notions of respect, meaning of respect. Because when I thought about it, and some of my own students' work, where communities talked about their izzat, and my colleagues in CBEC, izzat, izzat ke saath pesh aaye kya. And then it, in local context, in Karnataka, manam maryadi. You understand? Supriya can help me to translate manam and maryadi.
Yeah, Mana Maryadi, you're right on spot on that. It's also somehow linked to honor.
Can you translate it for colleagues who I'm unable to find?
Maryade is respect. I mean,
respect.
basically, whereas Mana is more of dignity and then or honor in that.
Yeah, but it's not so much honor as much as collective maintenance of that. It's respect more of at a collective level. But what I want to point out is when we have so many meanings to these things, how often have we who have anthropological training teased out its meanings at individual level for women, And also, see, you just now described the ASHA worker who was going through a divorce. Now, how often does a health system use the community respects her as a standard to identify her? And when that community respect is lost, sideline. You see this, the cascading meanings of respect across hierarchies in South Asian societies. Have we even see? So we can't throw words about like respect. We have to stop. See, if we are going to say we're going to decolonize these meanings, na, so हमारे लफ्ज़ें वहाँ आना चाहिए ना. I mean, our words have to come back there. We can't decolonize without colonizing with our words.
Yeah, definitely. I think the language, as Shripana rightly pointed out, how it plays around, because it's different interpretations even within certain communities within.
So we have to start talking about that stuff. And I just wanted to point it out that rather than buying in, a way to decolonize is to populate it with our language emerging from our places and the meanings. No, that is वो एक शुरुआत होगी. I mean, that would be a beginning. Sorry, I'm all over the place in language, but I hope I'm conveying. And Supriya is responsible for translating Manam Maryadi. I know it's
definitely.
No,
I agree. But I think it's so important to talk about, I mean, as rightly pointed out by Mala and then Shripana, the idea of language and its interpretations and how the meanings are constructed and the way we interact with each other with that, imbibed way of understanding. I think it's definitely, we need to really reflect and critically question these concepts. Sorry, so we have a question from Subek there.
Yeah, so if I may. Mala, those are absolutely important points that you have made. And Dr. Mala comes and teaches at CBEC. So that's why we're referring back and forth to each other. The issue of what a word means, what we read in ethics or in feminism, etc., is primarily in the English language. There is very little, at least in Pakistan, in our language that talks about it. Taking the word ethics, if you translate it into Urdu, it is translated as akhlaq. And when I don't know what it would be in Hindi or in one of your languages, akhlaq changes it completely. Akhlaq is basically your conduct of one person to another. It's conduct. Whereas when we use the word ethics, it is far more, it's this institutionalized, professionalized really now, which is ethics. So on the words, one of the things we try and do when we teach is we insist that students try to find that particular translated. And that in itself, and this goes back to what Mala says, brings in some of our local, I'm not saying our local norms or culture is always good, it's not. But I think that's very important. So thanks, Mala. We need to get you back here again somehow. And Amar is there too.
Thank you. Any other questions?
Yeah.
Okay.
You go ahead first.
Okay, so I'm Farid. I'm also a faculty member here at CBEC, new addition. So you were talking about decolonization in the field of bioethics. I've been listening here, the field of sociology and political science, but it was interesting listening from your perspective also. So I would like to know if there is any effort of studying the traditional systems of medicine in India, like Ayurvedic and the Unani medicine, which was practiced before the arrival of modern medicine. How, because I know these systems are being practiced in India now also, and how, in Pakistan also we have Tibbi Unani and Tibbi medicine. So how those systems practice bioethics in their systems? Is there any study or effort going on there to find a decolonial foundations for bioethics from our own history?
Anyone wants to answer, Shripana? Any thoughts?
I am not particularly qualified to comment on this. It's not my area of research, but one thing that I have understood from the limited reading that I have of this area is that the epistemology of biomedicine and practices like Ayurveda and Unani, as well as its ontologies, are very different, right? So as far as Ayurvedic medicine goes, it's very personalized, it's individualized, and the emphasis is more on sort of getting at the root cause of illnesses, right? So I think that will definitely influence both the practice as well as the ethical praxis and the clinical praxis, I would say, because Unani and Ayurvedic medicines are very, very holistic in nature, unlike allopathy. I think the problem now is that with Ayurveda becoming extremely commercialized, is that it's being held to the standards of biomedicine. So now there are large clinical trials which are being conducted on Ayurvedic drugs. It's a huge, multi-billion-dollar industry. So I think that one needs to be very, very careful in terms of how these practices are translated between these very, very different systems of medicines.
Yeah. So I know we are running out of time, so we have last two questions. Sakib?
Dr. Busha wanted to say.
Sorry.
Yeah. Yes, can I touch upon one thing? Supriya, you brought in the concept of how we define violence. And, you had brought it while you were giving your comments. Did you come up with anything in your research as how from the patient's lens or whatever, their perception of violence, what was violence by their definition?
I think Sripanna would be the right person, because I was commenting on her works, and then it made me question the phenomena, which is, of course, one is the violence understanding, but also disrespect as a phenomenon, like how we understand and question if it becomes a subjective understanding. But Sripanna, maybe you would be the right person to,
Yeah, so I can say that in the context of obstetric violence, there are very clear definitions in terms of what constitutes obstetric violence. I think the problem is it's not, I don't think the subjectivity itself is an issue, because, physical violence is a lot more easier to demonstrate. I think what is problematic is the evidence making. Right? So what can you provide evidence for? So my previous work has been on domestic violence. And one of the things that I found is that violence is notoriously difficult to establish when emotional or psychological abuse is concerned. So as far as institutions are concerned, physical violence is very easy to demonstrate. And I think it's also patients are, able to articulate it much more clearly. But emotional violence, emotional abuse, microaggressions, microinequities, the kind of discrimination that they face in their everyday practice, they may not conceptualize it as violence, but certainly as disrespectful care. And I think here is where, the polyphony of voices and the myriad languages that we have can come to our rescue, because the English language is very, very limited in terms of what, how we describe these things.
Yeah, just to quickly respond to the question too, like looking at microinequities, if it is a physical, like a word, as Sripanna says, it's very clearly, okay, there is something to, go on, hold someone accountable, at least in certain ways. But when it happens at microinequity, which makes one person question, wait, did it happen to me? Then that's an epistemic injustice in many ways, because it creates a tension. Did it happen to me? Did they mean it to me? That kind of a person who is at the receiving end. So then how do we describe violence is a larger question. I mean, if you want to put it in the larger obstetric violence debates and the existing literature. But I know we are running out of time. Sorry. So we have last
Yeah, Dr. Nandini had a point, and I have a feeling she would be able to address the question of, which our colleagues raised about alternative medicines and things. So could we hear her as well, please?
Yes, please. We have Sakib and then followed by Nandini. Is that good?
I just want to add a comment.
Yeah.
Can I?
Yes, please.
Okay. I'm also a student of the CBAC, and it was really a good discussion. I just want to add the perspective of the culture, like the Dr. Mozam have added, that the consent was taken by the husband. as in our culture in the India and in the Pakistan, the husband is a very prestigious figure, which is the women are emotionally as well as financially dependent in our culture on the husbands. So they even didn't register that they have a right to do the consent thing. And similarly, you guys just discussing the concept of the violence, even the maybe the women is not registering something which is violence for the rest of the world, because it may be maybe a normal custom for that particular woman. So I guess while discussing all these things, we must have to look into the perspective of the local norms and the local culture.
Thank you. Shripana, do you want to quickly address, or will you take up Nandini's question?
Let's take up Nandini's question, and if there's time, I can comment
Sure.
on that.
Yeah, thank you. Nandini,
Okay.
please.
Actually, it's a comment, not a question. Very interesting talk, actually. I will not actually talk about the other aspects for want of time. This is just about the traditional medicine that we observe in our country, various systems, Ayurveda, Unani, Siddha. We have Soa Rikpa also, which is Tibetan in origin, mixture with Ayurveda, etc., yoga and naturopathy. So these are the recognized systems by the government, along with homeopathy. Now, when we talk about ethics in research, whatever the Indian guidelines state is applicable to all types of research, including the traditional systems as well. So it's all about protection of the participants. So it applies to all. It's only the treatment modality which differs. And for it, actually, like when we talk about good clinical practice, the good clinical practice, the 13 principles that it actually enunciates, may be slightly modified for the traditional systems. I don't want to go into details, but I just wanted to highlight this. And there is also a move in India now to have interdisciplinary research, joining both the integrative approach, actually joining both the systems. And it is expected that by 2030, the education, the medical education itself will change, that there will not be different systems to start with at the undergraduate level. The teaching will be similar for any person aspiring to be a medical graduate. And it's only after graduation that they will dichotomize themselves into any of those traditional systems or the modern medicine. That's it. Thank you. Thank you for the opportunity.
Thank you, Nandini. So I know we are really we have no time, but then please, if you have any questions, like very important, feel free to reach out to Shripana or myself or any of us here. Shripana, do you want to say anything in the last?
No, I just wanted to say that I really enjoyed this conversation and, and the discussion with all of you. And perhaps there is an opportunity to have a second session on the idea of violence, because I think that's something that, is important. And it's not something that's addressed adequately in the literature. So what violence means in particular contexts and, what words we have for it, it's really, the question of community honor, right, versus the honor of the respect for. I think these are very, very difficult and issues to disentangle in the South Asian context, given this long history of violence against women in our context, precisely based on taking a revenge on the other community. So it's something which we need to think about very carefully and parse out when we are commenting on how there needs to be different definitions of what is constitutive of violence.
Right, definitely. I mean, I think it's brilliant. I'm looking forward to have another session. Maybe you can come on board with us and we can continue this conversation. So thank you so much for everyone. And Shripana, this is amazing. And I really enjoyed your works and to think through, and hopefully we'll continue the conversation and keeping in touch, definitely. So thanks again for everyone here. And thanks, Priya. Thanks, Suleha. Thanks, Sunu, for helping coordinating all these. And for everyone who is around here from Sabak and for all the bioethicists in South Asia.
All right. Good day. Bye.
Bye. Have a nice evening. Yeah.
Can the
Bye.
SAP community people just stay in the core team?
We can stay back. Yeah, that would be
Just
great.
for 2 minutes, yeah.
Yes, sure. Yeah. Thank you.